All right, 7 p.m. Are we ready? Are we ready to bring Andrea Ramberg up? I know I'm missing hearing Eminence Front. We're going to close with Eminence Front because, like a knucklehead, I moved some things around and I couldn't find them. But that's what happens. So here we go. We'll get cracking here. Again, this is the first webinar we've done this year, and welcome to Sleep World Magazine webinar, Bridging Guidelines and Practice CSA Management in Today's Sleep Labs, brought to you by Cadwell. I'm just going to move my camera a hair here. Brought to you by Cadwell, and we're very happy that they are sponsoring this. We'll have another one this year at minimum from them. I'm your host, Michael DiDomenico, the publisher of Sleep World Magazine. It's great to have you here on this cold night. Everywhere, it seems, in the country. Thanks for taking some time out with us, especially on your Tuesday evening. There are several links at the top of the chat to register. One is for Philly Sleep. Please register for that. Remember, it's the only conference in the country. It's the largest hybrid conference. So you can attend in person, which we love, at Live Casino in Philadelphia. It's a great meeting. Come have some fun, enjoy the food, see the 42 vendors. And that's on March 27th. If you can't make it in person, you can join us virtually, or you can purchase the recorded version. But all in all great. Whatever works for your schedule. And there's also a link there in chat to subscribe to Sleep World Magazine. That's the best way to do it, to get all the information for all the things we do. Get the magazine, get the emails, get the new Sleep World Weekly, which used to be Tech Times. We changed it. It's got some new stuff. It's now got articles and things in it. It's better. It's just better. This webinar is going to last about 60 minutes. We're going to hold all questions till after the presentation. Again, I will remind you, please put all your questions in the Q&A section, not in the chat. It makes it much easier to manage on our end. This activity is approved for one BRPT CSTE credit hour. The evaluation and certificate link will be placed in chat after the presentation. Please have your BRPT registry number ready because you're going to need it, because it's needed on the evaluation form. If you don't know your RPSGT registry number, we put the BRPT verification search link in chat. You got 60 minutes to get it. So you can just go to the top of chat. If you don't know your number off the top of your head, grab it there, and you'll have it for the form to fill out to get the credit. Today's webinar is Bridging Guidelines and Practice CSA Management in Today's Sleep Labs. The webinar will provide a comprehensive overview of essential sleep apnea, ASM guidelines, and practical strategies for addressing real-world challenges in sleep labs. Our presenters are Andrea Ramberg, MS, RPSGT, CCSH, FAAST, Jill West, BA, RPSGT, CCSH, Trish Fair, MA, RPSGT, CCSH, and Mary Blevins, RPSGT, CCSH. It's a great panel we have tonight. Let's bring up Andrea. Actually, let me read your intro first, and then I'll bring you up. Andrea Ramberg brings. Oh, you know what I'm going to do? I need a sip of water. Hang on. There we go. Andrea Ramberg brings over 18 years of experience in sleep medicine with deep expertise across every aspect of polysomnography, from hands-on clinical practice to administrative leadership. She's dual credentialed as an RPSGT and CCSH, and holds a Master of Science in Industrial and Organizational Psychology. Pretty impressive. Andrea serves as a Clinical Solutions Director at Enso Data, where she joined in 2020, driven by a passion for advancing the future of sleep medicine. And nothing truer could be said. From 2021 to 2023, she served as president of the BRPT, and she remains deeply committed to empowering sleep technologists to thrive in expanding and evolving roles across the field. It really is my pleasure to bring Andrea to the screen. There she is. Hi, Andrea.
Hi, everyone.
It's great to have you on board. I'm going to leave you in Andrea's hands. And I'm gonna get off the screen. I'll be here if you need me. And go ahead, take it away, Andrea.
All right. So as Michael mentioned, I'm surrounded by these lovely panelists. Another cool thing that's coming up is it's actually International Day Women and Girls in Science. So I thought that was extra cool that we got to bring this panel of wonderful women in science together to do this. Okay, so for today, my section will be covering CSA, common causes, and treatments. Before we dive into the protocols and what this means for your lab, it's important that we have a basic understanding of, central sleep apnea. So I'll be covering what is CSA, the common etiologies and risk factors, evidence-based treatment options, and emerging therapies. But before I dive in, there is actually a great webinar for those that want to go back to see it. It is actually on Sleep World's website. Dr. Bader did a central apnea back to the basics, and it's really great if you're looking for a much deeper dive. I will only cover the basics with this, but if you're really looking for more information, he does a really great job. Okay, so before we dive into what's abnormal, I like to cover the mechanisms behind what is normal. So that respiratory drive, that need to breathe, it travels through neural pathways from the respiratory muscles, which execute the breathing process and generate that inspiratory flow. In a healthy state, that inspiratory flow generation pathway is intact, and thus respiratory drive is satisfied by the rate of volume increase expressed by mean inspiratory flow, which in turn determines tidal volume. So again, we're talking about that neural pathway, and that's important when we're talking about central sleep apnea because that neural pathway gets disrupted. So when you're looking at the difference between obstructive and central apnea, a lot of us know this, right? We're techs, this is one of the first things that we learn. But that obstructive apnea, there is still that cessation in breathing, and that's comparative to that central. The difference between the obstructive and central, though, is I've always said obstructive is really noisy. When we're looking at our patients, those patients are the ones that are flailing, and we see their chest and their abdomen moving up and down for that work of breathing. In central apnea, it's really eerie. It's so quiet. They're very still because that work of breathing, that chest wall, that abdominal movement just isn't present. And you're going to see too with like that hyperventilation with that Cheyne-Stokes type viewpoint that patient's really trying to breathe, and that's that post hyperventilation that actually can cause that central sleep apnea. And I'll go into that here. So like I highlighted, the vast majority of CSA is post-hyperventilation hypocapnia. So that body is breathing so fast, that patient is breathing so fast that it brings down their carbon dioxide in the blood until it results in the fact that the patient just does not breathe. And it can also be the hypoventilation, that breathing too slow or shallow, but the majority is going to be seen, in this diagram with that Cheyne-Stokes respiration. And that's what those football shapes are representing, is that hyperventilation. And then eventually that CO2 reserve hits to that mark and then it stops breathing. And this, as we're very familiar with, occurs most often in non-REM. The removal of that wakefulness drive to breathe during non-REM sleep renders respiration critically dependent on chemical influences, especially the PCO2. So we talked about in that first slide that normal breathing is not with neural pathways. Well, this is actually shifting it then to those chemical influences so that our CO2 levels really determine what type of event that we're having here. And that non-REM sleep unmasks the apneic threshold. So it's a phenomenon that is sleep state dependent. And that central sleep apnea then occurs if arterial PCO2 drops below a highly sensitive apneic threshold. So you see that 45 to 35, and you see that line right there. So that CO2 reserve, they have all that, but you see that slowly dropping as they're hypoventilating more and more until it hits that threshold. And then they're like, oh, I'm not going to breathe anymore. Common etiologies of CSA. So heart failure, we see this in a lot of our heart failure patients. When I would round on patients in the hospital system, heart failure was one of the patients that I was always guaranteed to go see. 51% of male patients with heart failure had sleep disordered breathing. Roughly 40% of that is central sleep apnea. And the remainder, 11%, had obstructive apnea. So there's this tying right in with the disease states. Stroke or brainstem disease, 40% of the patients demonstrate central apnea after a CVA. So again, this was the patient population that we would see a lot in the lab. The theory is the brain injury disrupts that neural pathway that we talked about and that normal breathing respiration responsible for controlling that automatic breathing. So that just kind of disrupts all of that. It forgets to tell the body to breathe. Chronic opioid or sedative use, suppressing that central nervous system, which reduces the body's responsiveness to carbon dioxide and slows the respiratory drive. So it's almost like with that suppression, it's reduces that body's response to be like, hey, we should be breathing, like in that obstructive apnea where the body's like, okay, something's going on. That chronic opioid or sedative use just delays that. It just makes them more fatigued and less likely to respond to that. With high altitude exposure, at altitudes above 5,000 to 6,000 feet, low oxygen forces that really rapid breathing because they're not getting as much oxygen, right? So they're hyperventilating, which we know that then most central sleep apnea is caused from post hyperventilation, and they go hypocapnic. So and reduces the carbon dioxide in the blood just too much to where the body's like, this is where we're at. There's also idiopathic central sleep apnea, which we won't go into today. And then another thing, treatment emergent central sleep apnea, which if you've ever been in tech doing the titrations in the middle of the night, we are very familiar with this. You just wish that patient would just tolerate that CPAP, right? We're taught to try these different things and wiggle this little lever, but it could be really frustrating to deal with that patient population. So when we're looking at reduced left ventricular ejection fraction, so that's one of the key risk factors in this patient population with central sleep apnea. And on the right-hand side, you're going to see that normal heart diagram. And that heart muscle, everything is perfect. It pumps blood out of the left ventricle. But when you look at that right-hand side with that heart, that weakened heart muscle cannot pump enough blood. So what's happening is that reduced LVEF slows circulation and destabilizes CO2 feedback to the brain, leading to over and under ventilation cycles that trigger central apneas. And this is how we see Cheyne-Stokes respiration. And it's that variability, right? It's not just that steady state. It's the different ventilatory overshoots that body is trying to do to get back on its stable, level playing field. So we're familiar with ejection fraction. And I remember as a tech when all the stuff with ASV came out, and, we'll talk about those guidelines a little bit later here. But, the ASV is not indicated with certain patient populations if they have under 45% ejection fraction. Well, what that means is it's actually an ejection fraction of, let's just say 35%, means that your heart main pumping chamber, that left ventricle that you see on the right-hand side, is only pumping out 35% of the total blood volume inside with each beat. So it's leaving blood within that, and it's only pumping out that certain percentage. So it's not keeping up with what that body needs, which can cause a lot of issues. And more key risk factors, advanced age. It's estimated that 1.7 in the middle age group have central sleep apnea versus 12.1% in the older adults group. And whereas that older adults have a narrower gap between their normal resting CO2 levels and the threshold at which the brain triggers breathing, making them more prone to apnea when CO2 drops slightly. And then the male sex in of itself is a risk factor. Prevalence of central apnea in women is only 0.3%, whereas with men, it's 7.8%. And I found this really interesting. And a lot of it actually has to do with hormonal differences. So testosterone is linked to that higher loop gain. And what the higher loop gain is doing is it's an unstable respiratory control system. So again, we talked about this ventilatory going back and forth, and it can actually elevate the apneic threshold, meaning men require less of a drop in CO2 to stop breathing during sleep. So they're much more sensitive with that drop. So we talked about that, that threshold. That threshold is going to be a little bit higher. They don't have to hyperventilate as long to get to that. And men are actually also more likely to have heart failure. So, and we just reviewed that of how heart failure can cause that central sleep apnea. So evidence-based treatment options. How do we treat this? positive airway pressure. And there's multiple versions of that. So CPAP is actually estimated to work in about 50% of this patient population, which when I saw that, I was a little bit surprised. It's funny when you're doing these presentations and you're researching all of this stuff, some of the stats can kind of jump out at you. But it makes sense if you think about it, because there's a co-occurrence of that central and obstructive apnea. So we're treating both components at the same time. And potentially this is something that CPAP could fix in some of this patient population. But the theory with it is preventing that narrowing during that central apnea and then dampening the ensuing ventilatory overshoot. So it's keeping that stable breathing instead of having that body fluctuate as much. Another line of treatment is the BPAP with backup rate. And it's actually with the new guidelines, it's not to be used without a backup rate. And I do believe one of my colleagues will, discuss that in their presentation. But it's effective in restoring the alveolar ventilation during sleep. And the clinical indications include nocturnal ventilatory failure and central apnea secondary to hypoventilation. So again, there's going to be a certain patient population that this suits for. And then ASV was put back in the guidelines. They removed it previously, but then it is back in there because of the SERVE-HF trial, which we're all familiar with. But it provides varying amount of ventilatory support against a background of positive end expiratory pressure. So what it's doing is it's changing in respiratory effort, results in that kind of gives that patient breath when it needs it and takes it away when it doesn't. So it's constantly analyzing how that patient is breathing and giving them what they need in the moment. It's a very cool machine to watch work when it actually is working well. More treatment options. So there's supplemental oxygen. And the thought is that most likely explanation is it's increasing that cerebral PCO2 by the displacement of carbon dioxide from the hemoglobin by the increased oxygen level. So increasing that oxygen level kind of also alters that PCO2 that patient has in their body. The acetazolamide, it's a weak diuretic that causes mild metabolic acidosis and has been shown in several studies to decrease the severity of central apnea, specifically just to lessen that fluid retention. And then there's the transvenous phrenic nerve stimulation. And this is something that is relatively newer, and it's actually new in the guidelines. And it's an implantable pacemaker-like device that monitors breathing and stimulates the phrenic nerve to activate that diaphragm to get that patient breathing again. And it bypasses that brain's failure to send breathing signal. So it's kind of acting as that brain signal, right? Of like, we need to start breathing now. And another new emerging option for treatment emergent central sleep apnea is CPAP. And this was just FDA cleared just within the last 3 months, 6 months. And how it works is it's offering that variable pressure, reducing that inspiratory pressure while maintaining that expiratory pressure. So it's reducing the airway pressure during both that inspiration and much of the expiration, only returning pressure to the optimal treatment level towards the end of expiration, right? We all have those patients that are fighting against that in and out. And what CPAP is able to do is give breath when it's needed most, and it backs off when it's not needed, right? So it's able to better treat that treatment emergent central sleep apnea in a way that maybe your traditional CPAP device could not. And if you want to learn more about that, there's another great webinar that Sleep World put on. This is really great stuff. It really dives into the research and the science behind it. I think, whenever something new comes out, we as a field can be a little bit skeptical, but this really dives into some of the science behind it and allows you to kind of put that critical eye to it in a really great way. So to wrap this up and what my colleagues will be going through in their presentation, why CSA matters. So why does all this matter to us as techs? There's an increased morbidity and mortality in individuals with CSA, reduced sleep quality and daytime function with all of our patients, right? Higher cardiovascular risk, and early identification improves outcomes. It's part of the reason why, the inpatient sleep screening programs exist, right? Is that we're getting to these patient populations that need to be educated and cared for in a more timely manner. I heard so much that, sleep was an outpatient problem, but it's not. Your patient that is sitting in that inpatient and readmitting, this is something that actually we can take care of right now and educate that patient that they have options and educate the other medical staff as well. And then the sleep lab impact, accurate event identification. As a sleep tech, we have more power than what you may think. I've always said we're the eyes and ears for that physician. They're not there with that patient. We are. We can help identify a lot and then, give those appropriate titration strategies, discuss this with the physician of what we're seeing, guideline aligned protocols, as things shift and change in our field, how can we change how we're approaching those patients? And we're with those patients for so long that we can help educate them, on their options. And then a stronger interdisciplinary communication with all medical disciplines, right? Cardiology, the inpatient world, the sleep medicine physicians, everybody, to create that better patient care. Okay, so that ends my portion of the sleep presentation. I want to take this opportunity to introduce Jill West. She began her sleep career in 2010 as a night technician and now works as a clinical sleep specialist. She is a member of the BRPT Board of Director and chairs the Advanced Titration Certificate Task Force, which I'm very excited for. If you all have not checked that out, please do go onto the BRPT website. It really allows you to feel empowered to tackle this type of patient population. And then also is involved with the Exam Support Committee. On a personal note, the very first time I met Jill, I knew she was a force to be reckoned with. She just commanded the stage and she really knew her stuff. So I'm really excited to hear what Jill has to say.
Oh boy. Well, thank you for the warm introduction. Just want to make sure I get confirmation we can see my screen okay before I get going here. Perfect. There we go. Well, Andrea, thanks for sharing that information. It's really helpful to have an understanding of what we're looking at with regard to CSA. What are some of the etiologies, the newer treatments that we're available to have, and then what updates do we have from the AASM and the BRPT to help support the industry here. So with that, let's just dive into it. The first thing I want to start off with sharing is that AASM guidelines, they do more than just define terms. What they do for us is they provide clear pathways for technologists and providers for decision-making. That then serves as a means for us to standardize titration protocols, scoring criteria. I mean, how many times have we as techs or providers as well, you've gone through, you've analyzed a study, you step away, you come back and you think, man, I don't know why that was N1, that should have been wake, or why was that scored as a hypopnea when it should have been in central, right? So there's a lot of subjectiveness that can come into sleep. And so these standardizations allow for consistency, for us to have consistency from study 1 to study 2, between different techs at the lab, between different labs and providers, et cetera, and facilities. All to say, if we take that consistency, it's allowing us to help ensure that we're incorporating safe, evidence-based practice in our environments. And in truth, that better classification is going to lead and guide better treatment decisions. And now some of us have been probably on this call or maybe in the field for maybe 40 years or so. Some may have just started in sleep 4 weeks ago. So we don't have time to dig into the meat of all of the updates. So I just wanted to share where I'm getting this information from. So hopefully you can go and check this out on your own. It is strongly recommended, pun intended there. So if you do have a moment, I would head on over to the AASM site and then standard guidelines, clinical practice guidelines. And this is that paper from December of 2025 that I'll be referencing here. Now, that paper, there were 9 key updates there. There's some great, it's a really well laid out paper there. So please do take a moment to have a look at that. But with regard to time, let's just jump on in. So with these AASM updates, we really see them continuing to define and refine how we classify and treat central sleep apnea. And in this particular instance, we're seeing the treatment decisions guided based on how we're certainly classifying and reclassifying this information. So we're looking more at primary versus central sleep apnea. As Andrea mentioned before, it could be idiopathic, which means we just don't know why you have it, but you have it. So for me in particular, one of the more impactful updates was this emphasis on identifying underlying causes of OSA. So when we take a patient, sometimes we're just looking at this little tiny piece of the puzzle when there are other impactful features that may be causing these central events to occur. Maybe it's medications, maybe it's life, maybe they're snowbirding at higher elevations. So we're really taking a step back and looking at all the different variables that can be causing these events to aid in a better treatment plan for the patient. Now, with regard to modalities and contraindications, Andrea had mentioned this a little bit into her presentation, where originally back in 2012, ASV was recommended for central sleep apnea. And then many of us recall the SERVE-HF paper in 2015, the outcomes from that, which led to the abrupt pivot for ASV therapies in 2016. And so we have that contraindication for patients less than equal to 45% for their LVEF. Now, with these new updates, we do recommend, I say we, the AASM does recommend the ASV over non-ASV therapies in specific etiologies. And there are some conditional recommendations that go alongside that we'll cover in just a moment. It does also say, look, everybody, let's take a step back, look at the big picture and not these momentary events. So if, for example, during a treatment, a study, and you have treatment emergent centrals that come, we want to take a step back and really not jump into advanced modalities. We want to give the patients time to stabilize before we're escalating to those complex modalities. As Andrea had mentioned before as well, we don't want to have a BiPAP instance without that backup right there. We certainly want to treat centrals and not induce them. Now, this table here, this is a summary of most of those updates there, the key ones I'd mentioned previously for the ASV. Originally, absolutely recommended 2012, and then there were some changes to not essentially utilize that primarily as a therapy. Now we're looking to reintroducing it across multiple etiologies. I'm sure there'll be some hesitancy to reintroduce that into common therapeutic practices there. Now, just keep in mind, though, that if you do have a chance to look at that paper, there are some remarks with regard to for patients with a reduced ejection fraction that you should be monitoring that in an environment that is communicating closely with the patient. They are also experiencing that therapy. CPAP, not a ton of changes there. With regard to medications, acetazolamide, if I said that correctly, I practiced it a couple times, everyone. Now we are looking to use that also for high altitude central sleep apnea. So Colorado, I'm looking at you. They did remove some recommendations for some of zolpidem and other hypnotics. With regard to oxygen therapy, certainly are not unfamiliar with utilizing that, but it's also expanded to include therapies for high altitude central sleep apnea as well. For BiPAP, again, as Andrea had mentioned, you want that BiPAP without backup rate to be discouraged in most instances there. For me, I would say one of the more interesting feature or updates on this list is the outcome metrics. Traditionally, a lot of us, we've really been, kind of ingrained in our training is to focus on AHI, AHI, AHI. With this update, though, we're taking a little bit of a pivot and now shifting that emphasis on quality of life and functional improvement. So I'm really curious to see down the road if we have more of a shift in focus towards, maybe developing stronger patient relationships because we are more involved in looking at functional improvements to those patients, or maybe even hypoxic burden down the road. So TPNS, as Andrea mentioned, is a newer therapy option. It is certainly an invasive procedure, not as readily available and can be cost prohibitive, but it is nice for patients to have other options there. Now, all of this is great in theory because they're guidelines and they say, this is how we should be doing things in the lab, but sometimes it's not always that easy, especially when it's 2 a.m. and you're by yourself and you just don't maybe have the foundational knowledge to comfortably and confidently perform those procedures. So I want to share a little bit of an update from the BRPT. Now, the BRPT has come up with a new advanced titration certificate exam that's available as of January. So with that, there was quite a bit of requests from the field to say, hey, and the field, all the labs out here, we are seeing a more complex level of patient and some of the easier cases, so to speak, are just being sent home with an HST, and then they get set on an APAP. So now the patients we're seeing are quite complex. So how can we help train our technicians, and what materials do we be training them on? So this advanced titration certificate really does help address that growing need for complex titration knowledge. Hopefully also helping practitioners keep in line with industry standards, as this is a newer exam with refreshed materials. And also, in my opinion, promote a higher level of clinical understanding, because that RPSGT exam, it does test for minimal level of competency for techs that are entering the field. So if we can use another exam to help grow and encourage that development, that's what we certainly want to champion there. Now, with regard to the advanced titration certificate, just a brief review of the exam. It is 75 items. You can take it at home. It is not one where you have to go to a testing facility and go through all of that song and dance to sit for your boards. It is broken down amongst 3 domains. This was determined by a job task analysis committee where we got together and said, hey, what are important things to know when you are performing these tasks? And then how are you performing these tasks safely? And so there is a time limit for the exam. Upon completion, you do also get 10 CSTEs, which is certainly helpful to have some of those for credential renewals. If you go to, and I would certainly recommend going to the BRPT website, that's where these documents were obtained from. On the left-hand side here, this is the blueprint. So the blueprint is really going to map out this exam. So 3 domains, it'll say, of that domain, these are the other items that you should be studying. So it gives you a better perception of where you should be spending your time focusing. So maybe you are very proficient with titrations and you need to focus maybe a little bit more on the respiratory side of foundational knowledge. So it just provide guidance in that regard. The right-hand side, these are the approved references to study those materials, because there is a myriad of different resources available out there. With the approved references, the committee, the task force, I should say, we did strive to source low or no cost materials just to make it more accessible for everyone. Now, what I'm showing on screen now, that is specific to the advanced titration certificate, but it is a very similar process for all of the other credentials and certificates we have. So CPSGT, RPSGT, CCSH, this exam, and the pediatric certificate, they all have blueprints. They all have approved references. So if you are looking at advanced credentialing or just starting out in the world of sleep with your certificates or credentialing, I would start there. Have a look at the blueprint, help it to guide and map out what you want to study. And then when you're looking at what resources to study, have a look at those approved references there. In summary, because we've covered quite a bit of information, we still have quite a bit to go. Really, the December 2025 update from the AASM, in my opinion, it modernizes CSA treatment. It utilizes PAP therapies that we have, oxygen therapies, different modalities, and also some medicinal therapies there. Again, as I mentioned, though, for me, the emphasis on patient outcomes and quality of life improvement, that is the real winner to help build strong patient relationships and also strong adherence to compliance, which is really going to be quite impactful. With regard to the BRPT, that certificate exam, it really does stand as a meaningful way to help recognize advanced competencies in the field. So I'm very excited to be able to be live with that one. Now, these clear guidelines that we have from the AASM and an extra credential from the BRPT now, it's all great, but when it's 2 a.m. and you're by yourself and things go sideways with your patient, it's hard to remember those foundational aspects. So I'm going to introduce Trish Fair as the next speaker to go through what this looks like in the real world. Now, Trish Fair, she's dual credentialed in sleep and EEG. She runs the lab at one of the largest outfits down there in South Carolina, or in the Carolinas there. She does also instruct at the Greenville Technical College in Greenville, South Carolina. So Trish, I'll pass it over to you.
Thank you, Jill. Okay, so I'm going to jump in talking more about what we can do in the lab to ensure our success. And I think my PowerPoint's going to follow me up here in just a second. There we go. Okay. So with new guidelines and old guidelines, how are we successful in the lab? And I broke my section of this talk into 5 areas. I'm going to talk about the tools to make us successful, preparation, rubrics, documentation, and feedback. So to make sure you're techs, or if you're a tech, you want to make sure you have the tools that are going to allow you to succeed. And the first 3 are the ones that I think are really important to technicians. We need to have belts. You saw from the pictures that Andrea presented, we need to be able to see chest and abdomen, so our belts need to work at all times. This can be hard. You might have a set of belts that worked perfect one night and the next night you can't get it to work. So I put up a few different pictures. The recommendation I have is that you have multiple styles of belts in your lab so you can switch them out and find the right set for your patient. Same with your pulse ox, multiple styles in the lab to make sure that you find one that fits your patient well, it's not too tight, and you can get a really nice oxygen channel throughout your entire study. We have found too, if you're lucky enough to be in a lab that has blanket warmers, that's really helpful. But if not, we've learned to use hot hands. This is a great little tip and trick for patients with circulatory issues. Their fingers are really cold and you can't get a nice signal throughout the night. I consider paper speed a tool. Knowing how to look at your respiratory events, when you should be on 30 seconds, when on 90, 120, and 300 seconds, so you can get the best quality titration. Also to use that 600 second or whatever the highest paper speed you have on your system. If you see more than 5 central sleep apneas, you're going to want to do a review maybe every 2 hours, maybe once you hit optimal, to take a look at that, what everything looks like at 600 seconds so you don't miss Cheyne-Stokes respiration. Of course, we always recommend that there's multiple mask options in the lab, and as masks get expensive and there's patients come in and they want to try a certain mask and you know it might not work, we've gone to using the AI facial scanning software because it's really great in helping you narrow down the right size. This way you're not opening multiple packages of masks. Adjustable beds, this is going to be a tricky one. It's a great tool. Patients come in, they sleep on an adjustable bed at home. If it's something your lab can do, it really helps you create the exact same environment they have at home. So getting started, the pregame check, we call it a pregame checklist, knowing what you need to know so you can create a really nice game plan for your patients. And so for all of our technical staff, we set them up with a checklist that they have to do before the patient even arrives. What we want to do is make sure they've actually put their eyes on the actual order from the physician, have a sense of what they're expecting to see in that patient based on previous studies, based on the history and physical, based on if there is an ejection fraction rate available. And what did the previous studies tell you? Learn from what was done before. What do we know about this patient? What's already been tried? What worked? What didn't? And what don't you know? You might have a patient that your baseline is a home study. Okay, well, we do know that you may not know exactly what type of apnea that you have or a really clear picture. You just know that they do have apnea. So, and reviewing compliance data can be incredibly helpful. How long do they wear their titration at night? Are they successful at home? Are they taking it off every 2 hours? Those are things that are all going to help you in the lab be prepared for your patient. I really encourage everyone to take time on their interview, listen to your patient, hear what they have to say, what they're worried about, any anxiety they have about therapy, and that's an opportunity to build trust. And if you build trust with your patients, then you're going to have more patient confidence, and they're going to trust you to do things, to try a different mask that they didn't want to. Maybe at 3 a.m. they don't want to do this anymore, they want to leave. But if you spent that time in the beginning just letting them talk to you, then there's a good chance when you say, hey, can we give it one more shot, they might do that. We also advocate that all mask fits are done separate of the actual setup. It's really hard for patients who've never had a mask on before to have it on with paste and tape and wires and everything going on. It can be complete sensory overload. So once you have your pregame checklist in play, you have a sense of who your patient is, then you really want to build a nice foundation. Start your studies in a way that you don't have to deal with these things later on. Strong impedance, nice bundle. One of the things we do, as Jill mentioned, we have an A-STEP program through our local college, and so we have a pipeline of new hires. And when we have a new hire in here, they actually do all titrations because they have a preceptor. So that's our opportunity to get them exposed to masks, exposed to how to control a leak, when to change their mask. And then once they've gone to the stage that they no longer have a preceptor, we bring them back and do a lot of PSGs and split nights. And rubrics. I'm a huge advocate of having decision trees, things that we can use to set us on the right path, as well as to help us the wire. So there's two that I recommend. AAST did a clinical guideline back in 2021, and then the Journal of Clinical Sleep Medicine also put out a clinical guideline. They're very similar. They both recommend titrating at 1 centimeter. Your lab might allow you to go up on 2s. They both recommend that you stay at least 5 minutes, but of course you want to develop your lab protocols. How long do you stay at a pressure before you move on? Is that how long you stay of total sleep, or how long you just stay before you try something else? These rubrics are for CPAP and BiPAP. Currently, there isn't a rubric out there for ASV. And we found that staying on ASV on each pressure for 40 to 45 minutes has been incredibly helpful before changing and moving to something else. But these rubrics are great for technicians with a lot of experience, as well as new technicians to see, what do I do next? Well, you count your events. How many hypopneas do you have? How many centrals do you have? How many obstructives? And these decision trees will tell you where to go next. We actually are a little old school. I highly recommend having some worksheets that are on paper. This isn't going to be connected to the final software, your digital study. This is something that you can use in your lab for feedback. It's really hard to give someone feedback if you don't know why they did what they did. Having these types of worksheets, and we develop them in different stages. What you're looking at and able to understand in week 1 and 2 is going to be very different to where you're at week 5 or week 8. And then we have standard ones and we have different versions, because different techs like different styles, that we're able to use. So when a study goes a way that we didn't expect, or we don't have the outcome we want, we can look back at this worksheet and see where the decisions were made, what they were based on. And that really helps to provide quality feedback. So in the article that Jill mentioned, something was listed in there that patients frequently have mixed disorders. We've all seen this. The patients will come in and you see obstructives and centrals and hypopneas, and their oxygen levels are dropping, and it's all going on at the same time. So it's really important to focus. What are you going to do first? Set your goals. First, you're going to eliminate apnea, and then you're going to look at hypopneas and oxygen levels. Now, I'm going to just focus on goal number 1, because that's the premise of our talk. But our first goal is to eliminate those obstructives and those central events. So what are our tools to do that? So when we look at our tools, we have all of our modalities. We have our positional sleep. We have oxygen and mask changes. And so if you're using your rubrics, you're starting on CPAP. Then you're going to BiPAP. Well, we're dealing with apnea. So we know we're not going to adjust our pressure support. We're not going to have a gap. We're going to use BiPAP. Now, if you have only central apnea, then this might be use BiPAP ST first, or you might be in a lab that changes the order of how they do this. And this is why the lab protocols are so important. But you're going to go CPAP to BiPAP of some version, ASV, then you can go to positional sleep and add oxygen. Those are all the things that you have in your toolbox to eliminate apnea. And then somewhere along the line, you might need to do a mask change and see if that helps with your outcome. This article also mentions that the pathogenesis of CSA can vary depending on their clinical condition and the tech. And we've already mentioned once, treatment emergence central sleep apnea. Nobody likes when these appear. It's frustrating. They're harder to identify, especially if your baseline is a home study. Was this because we put them on treatment, or were these in the baseline and they just weren't identified? And even if you have a baseline, it might be 2 years old, it might be 5 years old, and we have patients that the insurances are accepting 10-year-old baselines. So the clinical condition can definitely change. Your lab wants to establish a protocol on how you're going to do this. Just another decision tree. For us, we do the go on and find out, but we have a point that we set. If we turn on CPAP and immediately centrals and we go up on 3 adjustments and nothing changes, we don't see any improvement, that's our stopping point. We're going to move to something else. You might be going along in your study and you go up 1 pressure and suddenly you're seeing these treatment emergent sleep apnea. Your lab might say, okay, we want you to push through for 2 or 3 pressures, Or maybe you're close to that turning point for your lab where your lab says we go to BiPAP somewhere between 12 and 15. You're right there at 14. Maybe you're just going to go ahead and make that change at that point. But there's nothing wrong with going back. Go back to the last thing that worked and then take a different pathway, choose a different modality, and make a change from that point. It's really important to have realistic goals. Yes, we all want that perfect study. We want that study that the patient gets up in the morning and the best sleep of their life. Sometimes that's not going to be accomplished in the first night in the lab. Maybe what you accomplished is acclimation. Maybe the patient who thought they would never do therapy is now going to do therapy. And that's because you were patient, you listened, you helped them get acclimated, and then they come back. Maybe you weren't able to figure out their therapeutic pressure, but you did figure out what's not going to work. So you took them as far in the pathway as you could. Make sure you're always controlling your leak. Is it really optimal if that leak is going on? And your documentation, tell everybody what you did. You're asleep during the day when the study is being finalized and people are making decisions. Those notes that you provide and showing where you were in your pathway is incredibly helpful. I know I've said the word rubric a million times already in this talk, but I really go back to it because what a lot of times people don't understand, it doesn't end in the sleep lab. You may have found the perfect pressure, patient had the best night of their life, wakes up and gives you a hug, but then the DME tells them they cannot have that modality. You need to make sure that you prove CPAP didn't work, BiPAP didn't work. You might have a patient that presented with over 50% central apnea in their baseline. CPAP didn't work, you go to ASV because you know it's going to work. But the DME says, no, there was no BiPAP or BiPAP ST on this study. You have to do that first, or the doctor needs to write a letter of medical necessity. This is going to delay the patient on getting the therapy. So take the time, go through the steps, check all the boxes so that the patient doesn't have any delays. And then finally, feedback. I broke this into 3 sections: collective, independent, and one-on-one. But any opportunity, whether it's physician case reviews, reviewing your physician's report on your own when they're finished, see if they match, they pick the optimal you did, do your inner score reliability, do a tech review yourself and present it to your manager or supervisor and ask for feedback, show them what you thought you should do differently. But if you're working from a management point, always highlight the good titrations, encourage your staff, show them what they did well, and help them get to the next stage on the other patients. I'm going to go ahead and turn it over to Mary, who's going to show you some actual case studies. Mary Blevins has been in sleep medicine for over 2 decades. She's done clinical care, research, leadership with all patients of all ages. She has an extensive background as a lead tech and manager, and that gives her really unique insight to guide facilities through complex system implementations. And in addition to her primary role, she contributes to the industry and has volunteered on BRPT's exam development committee.
Thank you. So I get to wrap things up here for everybody, kind of taking all of the information that Andrea, Jill, and Trisha just talked about and kind of present it in what we might have actually seen in the lab. So I've got a couple of different kind of cases here that we're going to be able to walk through, all just a little bit different. So in our first case here, this was a patient had a home test back in 2017. Diagnosis was an REI of 48.4 and minimum SpO2 was 88%. Not too bad. Our stats on our patient here, 6 foot, 220, BMI is a little bit high. Epworth isn't that bad, 7 out of 24, with a neck circumference that's pretty thick, 16.9 inches. The history of hypertension, GERD, OSA. Patient, because they had a home test, they were prescribed an AutoPAP. We see this all the time. 5 to 8 centimeters seem to do fine, except we still have a residual AHI of 15, primarily with centrals. So patient then had to come back into the lab for an actual titration so we could fine tune those things. In this case, we started with a patient that had a preferred mask they were already using, an AirFit P10, so some pillows. Sleep latency on the test in the lab was great, 4 minutes, right to sleep. Initially, when we're titrating, we start to see some centrals that start to pop up partway through. We're already a little bit above what they're normally sleeping at home. Leak was okay, still controlled, but slightly increased. So tech decided, let's go ahead and switch them over to a full face mask. See if that helps and if maybe that might be the cause of where some of our centrals could be coming from. So we spend a couple little changes here with those with the full face mask from 9 centimeters to 11 and 13. But we can still see patients sleeping. We're even getting REM sleep, but we do have centrals that are present. Patient woke up. We felt the leak was still controlled. It was about the same as it was with the pillows. We switched them back to a pillow mask. And as Trish mentioned, we kind of dropped things back because those centrals were there. Is this that treatment emergent central sleep apnea that we're seeing here? So we drop them back down in pressure for a little bit. Centrals are still present. So we end up moving over to bi-level. This is where we start getting into that space, as we've heard. What do we do with a rate, without a rate, things like that? Typically, most labs, a lot of us, we tend to start without a rate first to see how they're going to respond, and then we might apply a rate later. In this case, we did a couple of changes on that rate with the bi-level, increasing that pressure support that was there, and then we ended up stating apnea is still present, these centrals are still persistent, and moved them over into that ASV therapy. Once they were on that therapy, though, centrals just disappeared. Patient was able to sleep just fine, on their back, in REM, no central sleep apnea, everything looks good. Doctor decided to order that ASV for the patient. Next case we have here, another instance of a home test. This one we have a 67-year-old female, diagnostic REI was 62, with a very low saturation of 67.6 and spent the entire time sleeping on their back. What's interesting about that severity of that apnea diagnosis is when we look at the patient's height, weight, BMI, neck circumference, everything wouldn't suggest that this patient would have a severe apnea diagnosis. Mild, possibly, not necessarily severe. We have a history of rheumatoid arthritis, hypertension, AFib, hypothyroidism, migraines, diabetes. There's a lot going on with this patient underneath everything. But given the severity of this OSA with that patient, the decision was not to give an auto PAP. Let's bring them in and actually go through a titration. This patient, though, proved to be quite difficult. Had to do several titrations. This is where we've got to take it slow. We've got to be diligent. We've got to understand what may be happening here. So we started out first study, CPAP to bi-level. Let's go slow, see what's happening. Problem is that even from 5 to 11 centimeters, we had persistent OSA, just wasn't addressing it. It was at that point when we switch over to bi-level, that's when our central apneas suddenly became dominant. We had to understand what was needed. This study, taking it slow throughout the entire night, there wasn't an optimal pressure that was found. So unfortunately, we knew right away, patient was going to have to come back for a second full night. This one, we knew we had to start out with bi-level, so we started out fairly slow. You can see through that pressure change throughout the entire time on bi-level without a rate, the central sleep apnea was quite persistent. It wasn't until we added that rate to ensure that we were continuing that airway and allowing them to breathe that it then dropped everything down. And it seemed okay at 4.4 with this central apnea completely controlled. During a compliance check and a checkup with the patient after having been on therapy for a while, we had quite a change. The compliance ended up showing that they had significant central apnea still, even after that titration where we thought things were control. And now all of a sudden the Epworth scale is more than double what it was when we first had our home test done. And the patient's just stating that they feel uncomfortable when they're sleeping. They're just not feeling well. Going back to what Tricia was talking about, assessing the patient, seeing what's going on. What are they doing at home? Where do they feel they're most comfortable? Well, the tech sat down, talked with the patient, and realized, the patient doesn't feel like their airways really open up enough. So they got creative. They used an airplane neck pillow, applied it to the patient, which helped to elevate the chin during the entire time that they were sleeping. And that then allowed us to start back over again, go back to that CPAP setting now that we have a very controlled airway, and allowed us to titrate through the night. And we started to see, as we made our increases, we were controlling not just the centrals, but also those obstructives that were present. We were able to get those values down into a range that felt more appropriate. Saturation levels were up. We weren't seeing anything dip very low. And for good measure, we made a test and switched over to bi-level for a short period of time. In this case, patient was ordered to be able to go on CPAP, 13 centimeters, just have to wear a neck pillow while they're sleeping. Last case is even more interesting. This one, we have an older gentleman, had a diagnostic test in 2015 with an AHI of 19.2. History, hypothyroidism, rheumatoid arthritis, benign prostatic hyperplasia, depression, and hypertension. This instance was interesting because the patient wasn't actually well followed initially after their initial diagnosis. So we get in, we've got somebody who's following, checking the patient a little bit more diligently. When we run a compliance report from day 1 to 47, we see that on therapy, their AHI is higher than what it was during their diagnostic test, which is a little concerning. Patients at 8 centimeters of water with an EPR of 3 applied, they're really compliant. They're wearing it every single night. But when we look at the breakdown of everything, centrals are huge. We have an index of 15.5, and they're spending over 2 hours with Cheyne-Stokes respiration. That's a concern. Something's not right here. So we have to start assessing what's going on with the patient. What are our concerns here? And what's interesting and stood out to me is I've got a patient that's on 8 centimeters. Do I really need to have an EPR of 3 applied? EPR can be really great helping patients acclimate to therapy, right? Because it's a little bit difficult when you're first getting used to things, having a constant pressure come at you, being that you have an ability to kind of release that a little bit on that exhale can be really nice and comfortable. So we decide you're compliant, you're sleeping well. What happens if we pull that EPR down a little bit? So after our visit, EPR was dropped from 3 down to 1. We do another check-in at 60 days and notice how far our central apneas have dropped, all the way down to 6 from 15.2. And our Cheyne-Stokes, we've now reduced it down to 39 minutes, making dramatic progress. So if dropping it from 3 to 1 worked, patient still sleeping well. We had one night we didn't sleep very well. Could have been something else that happened. But what happens if we now remove the EPR completely? So at our 90-day check-in, patient's still completely compliant. Leaks are still within normal range. EPR is turned off. Our central apneas have now dropped to 2.4 an hour. And we have Cheyne-Stokes respiration for maybe 4 minutes out of the night on average. So it's always good to kind of assess the situation, right? I would always tell patients when they were coming in and kind of trying to understand what was going on with the treatment and how to understand, what's appropriate or what's not. The thing that always kept me in sleep medicine was that sleep is like a puzzle. The one thing in neurodiagnostics, we can't necessarily pinpoint to one specific area in the body. It's a puzzle piece. It's all these elements that we have to pull together. So when we're looking at these different circumstances and what the causes of these different types of central sleep apnea situations may be or where they're coming from, it's always, you got to take each situation at its face value. You've got to talk to the patient, kind of be proactive, work with each other to really see if we can find a common ground to maybe clear it up and help them all sleep better. So I know it's been a jam-packed full hour. Appreciate everybody kind of spending the time to let me run through some of these different cases and show how guidelines and day-to-day realities can kind of come together to present the whole thing in the lab. So with that, I'll go ahead and pass things over to Michael to go ahead and lead our Q&A.
All right. Thank you, Mary. Great job. Great job, everybody. For some reason, I'm in a weird screen here. Oops. Let's adjust that. There we go. I'm going to bring everybody on screen. We're going to head into the Q&A now. So here comes Jill. Here comes Trish. There's Andrea. Like I said in one of my social posts, I'm a lucky guy to have such a great panel tonight. And I think you guys really all did a great job. And I think this is going to be even the best part. We're going to head into Q&A. And there's quite a few questions already. I'm going to turn on your microphones, okay? There we go. Should all be there. As a reminder, I did ask everyone to put the questions in the Q&A. I think we'll work from the bottom, so we'll go back to, actually, let me bring this question up anyway. Hang on, let me approve this. Can I spotlight it without approving it? Yeah. This is actually directed to me, but I want to just address this because these kind of questions come up a lot when it comes to credits and things. Allison asked, what if you don't have an RPSGT number? I'm an RRT with a PSGT license in Iowa and need 8 sleep C my renewal. My first suggestion would be to go to the Philadelphia Sleep Conference. That's just me. That's what I would suggest. But and I don't know how it works in Iowa, but what I typically tell people in these cases is, and Andrea, having been the past president of the BRPT, might have some insight into this as well. I usually tell people that I would send the certificate to the board, to your local board, the Iowa licensing board, and see if they accept the credit for this. Andrea, would that be the best method?
You know what? Because I'm not currently on the board anymore, I'm going to hand this over to Jill, who is currently on the board. She might have more updated procedures.
Can you rephrase that question for me here?
So, one of our attendees is an RRT with a PSGT Iowa license, and she, of course, wants this to count towards her recertification in Iowa. And as I said, typically I will tell people to present these, send the certificate in or contact your board. It's probably a better way to do it so they know what's going on, and say this was a BRPT approved session, webinar, whatever course, and hopefully they will accept that.
Yeah, well, so for sleep, I would touch base with info@brpt.org for clarity on that. I don't want to speak out of turn on here, and I'm not involved in that part of the BRPT. So yeah, info@brpt.org. We'll be able to get you squared away.
Okay. And I would also contact your board. I think it's more of from what I understand, it's really more of an Iowa board question. But yeah, you could, Allison, attack that from both angles, and hopefully you can get that approved. But in all seriousness, the Philadelphia Sleep Conference is accredited for both respiratory therapists and sleep technologists and physicians, for that matter. So there you go. So we'll start with the first question here at the bottom. So I got to assume this was for Andrea. The BPAP with BR not to be used without BR. Is that only in regards to CSA?
Yeah, so that was within those guidelines is what they're saying, that to make sure to use the backup rate when you're treating central sleep apnea. Yep. So without the backup rate with bilevel, you could definitely use that with the treatment modalities to treat obstructive sleep apnea, hypoventilation, all that other, what you would use it for your other patient population.
Good. From our friend Emma Cooksey down there in freezing Florida. Andrea, are there specific reasons a person would be offered a phrenic nerve stimulator implant? Does that just work for anyone with CSA or only certain patients? Great presentation, she said.
Yeah. So with that is a much deeper dive than what, there's a lot of different guidelines with how a patient would qualify with that. We could certainly take that offline to kind of go more in depth with that, but there's certain guidelines, just like with any implant device, that they want you to meet before you're eligible for that.
Good.
And thank you.
Oh, go ahead. I'm gonna since you brought up let me extend the time here. Since you brought up KPAP, Melissa R. Riccio would like to know. Trying to bring it to screen here. Hang on. That may have popped it to the top. Hang on. Yes, it did. Was KPAP approved by the FDA by itself or with the Cricket PAP device?
You're asking me all the hard questions here. I would go to sleepres.com to get all the information with the FDA clearance.
Well, and I think with KPAP, it's only available with the Cricket device anyway.
Yeah.
So,
Yep.
So to say it was approved by itself, I don't think so. And I don't think you'll see it turning up in any other devices since it is proprietary by SleepRes. All right, let me scan back down here. We have a lot of questions. I'm not sure who this is for, so whoever wants to tackle this one. Jorge said, Ray De Castro, the ASV treatment could be used in patients with biot respiration. Is that spelled correctly?
We can't see it.
Oh, it's not on screen?
It was there for a second and then gone.
Oh, there it goes. I'm click happy over here. Anybody?
I don't know what biot is.
It's not our friend George Ray. Of course, he'd be asking the tough ones. I would have to defer to the medical provider on this one. It wasn't specifically called out on that publication, so I'd have to defer to the medical provider in this instance. But yes, biots. Yeah.
Okay. I was too slow with this. Rusty, I got to say. All right. Moving on. No one highlighted for this one either, but whoever wants to tackle this one. How can be so sure of CSA without having intercostal leads?
I'm jump in with something else in the chat. There's multiple people saying they need to leave to go to work and looking for a link. Do they need to wait till the Q&A is over?
No, since we're past the 8 o'clock hour, hang on, let me put that in there, guys. Thanks for catching that. Since I'm in the Q&A, I didn't see that. I'm going to put it in chat. This is the Q&A. This is the CEU link. Remember, this webinar is approved by the BRPT only. So that is a form to get your CSTE. Let's go back to Q&A. And I think I took it off. I think it automatically takes it off screen. So let me go back. Who wants this? Who wants this one?
It's a great question. I think in the lab, we often have to approach things by what we think we're looking at. Yes, we all wish we all had the best equipment on the market at the time. I mentioned having multiple options is helpful too, but sometimes we don't know for sure. And we'll titrate based on what we think we're seeing. I can share at a technician who was convinced they were seeing obstructive. They were convinced they were seeing hypopneas, and so they were following that protocol, and nothing was working. Opened their pressure support all the way, did all the things you would do if those were hypopneas. Brought the patient back, treated it like they were obstructive, and it worked perfectly. So sometimes you have to apply the modality. The modality is not working. You need to know when to titrate back down and try something else to confirm that what you think you're seeing is what you're seeing.
I would add to that, I think one of the other things that I employed as being able to identify some of those things is a CO2 monitor, transcutaneous monitor. It can be really, really helpful. Like Andrea had pointed out, when we have people with central sleep apnea, their CO2 levels are a little bit different than what we might see in kind of an obesity hypoventilation patient. So it's all those different tools, like Trisha's saying, being able to have at your disposal if those are possible and you can't have maybe intercostals applied.
All right. Got another one for Trish. What AI facial scanning tool, I would assume, are you using?
Allowed to promote them. So I'll put it this way. At the time I looked, there was 2 companies on the market that were not manufacturer affiliated. We went with one of them. Michael, am I allowed to say who?
Sure.
Okay. We went with CSH because we were able to say what we wanted, what mask we wanted listed. So the technicians don't get options for masks that they've never had before. I'm getting a thank you for attending.
Yeah, just
Okay.
if you get that on your screen, just put like an X in there and get rid of it.
Okay. We did great, and to move on.
Best webinar ever.
Best webinar ever. So sorry. So we use CCSH because they allowed us to build in every mask that I have in the lab. And when I change masks, when I get new samples, I can put it in there. So that's why we went with them. But we did choose a non-manufacturer because we are able to carry the 3 main manufacturing labs. So that's the reason. But I think they all work. We tested for 2 companies. We got to test their AI before it came out, and they're great platforms to use. I think I'm a big advocate.
Yeah, CSH is product agnostic, so it is a nice option for that reason. All right. Sorry, clarification question. You said, and whoever said this can recognize this, no gap for BiPAP is the no pressure support at all, which is CPAP or standard pressure support of 4. Also, I thought the previous speaker just said that BiPAP was only to be used with a backup rate. How does that correlate to our normal standards that we have to have a CAI of greater than 5 or a 50% or greater? Wait, is there more here? Hang on. No, that's it.
Yeah, and thank you for bringing this up, because I'd like to clarify. I pretty much used slang from work, meaning your gap is in the tool. So we say that in our lab, don't touch the gap. You are dealing with apnea's no gap, meaning that's not a tool that you have available for you. But yes, BiPAP is a standard set pressure support of 4. I'll modify that slide because I think it's a great point. It made perfect sense to me. So also your lab has to establish their protocol. So I have a physician that encourages us. We have new recommendations. I don't know if he's going to change his mind, but we try BiPAP first. Also, I mentioned one of the slides, you often have patients with mixed things going on. So if you've still got some obstructive and some centrals going on, you've got to know in your lab what your next chain, like where do you go next, and just have that established and your stopping point. That's why I brought up the stopping points. You try the next modality, but for how long? Not forever. Like if it's not working, we kind of run a 3 to 5 pressure rules. If it's not working, it's not working. So that's where, and I kind of mentioned they're interchangeable. I have another physician that we go to ASV and then back to BiPAP ST. It's just the way they want us to run our protocols in the lab. So I think you have to, of course, if you attended this talk, take this back to your staff. What are we going to do? What's our lab protocol? And get your medical director support on how you're going to use your tools to accomplish what they're asking you to accomplish.
I think I would add also to Trish's statement, a lot of this also depends, because I saw some of the chats that were going on too. Some of it depends on what your territory, what are reimbursements for, right? Because some places you have to fail BiPAP without a rate before you can actually go to a rate. That's kind of the little gotcha with a lot of this, right? We have recommendations from the AASM, but insurance doesn't always maybe necessarily play along with those recommendations. So sometimes you have to be aware of what your kind of standards are in your territory, as well as, like Tricia said, what does your medical director want you to do as far as your protocol and your policies?
Good, moving on. How do you treat patients who tell you they have led a full life treatment on PAP not necessary for them? Oh, okay, I get it.
If they came for their study, they're not 100% against it.
Yep.
So I say, well, you came and I'm here and I don't want to lose my shift tonight. So let's see how this works out.
That is very true, right? What motivated them to come to the lab for a study or to come to the DME office following a study for treatment, knowing what that treatment entails? I think it's really important to go take a step back. You hear what the patient said, but also understand their motivations for saying that. Is it because maybe it's, a vanity thing, or they're at the point where they want to travel and don't want to have to lug around this other bag and figure out power supplies and batteries? Is it that they just don't understand the risks associated with not utilizing or being tolerant to therapy. So I would take a step back, fully understand the situation. Everyone has different learning styles, so really try a multidisciplinary approach when you're speaking to this patient, or visual cues, or actually seeing the equipment, and just really suss out where they're at with this, because it may just be that they don't have the full understanding of what the treatment is or the risks of being untreated.
Hi, Jill. For the advanced titration certificate, if a tech is credentialed through their respiratory license, RRT/SDS, are they eligible to sit for the exam, or does their sleep credential have to be through the BRPT as an RPSGT? There's not more there. I thought there was.
No, that's okay. So I believe I should know this offhand. I believe there are 3 eligibility pathways to sit for the advanced titration certificate. One of those pathways does include additional healthcare credentials with hours and experience associated with it. So I believe you should be appropriate or could sit in that instance. You do not have to be an RPSGT to sit for the ATC exam. If you head over to the BRPT, they have the eligibility pathways listed there.
Next
Michael,
one.
I can get that link so you can put that into chat here.
Okay, good. All presenters. So whoever wants to dive in on this one, I've seen a divide in how physicians approach initiation of addressing CSA specific treatments. One group wants to give the patient a transitional period on CPAP, noting that roughly 50% of the patients will resolve upon continued use. Another group will say they want to address the CSA immediately, as it's their one chance to have a favorable first impression on treatment, and the untreated central events may cause a poor experience and reduce overall compliance or therapy abandonment, and not try an advanced therapy. What say you? Says Andrew Blunkus. Anybody?
Those Utah folks, I tell ya. Can we pull that question back up? I couldn't quite catch
Yeah,
the
I don't know
bottom
why
part
it
of that.
popped out there. Could they give you that back?
It cuts off at another group's will say. So if I'm understanding correctly, in my opinion, you do have very limited time in the lab. And so yes, as a tech, you want to get everything done, and then you pass it off to the DME, and the DME will figure it out. I can say that because I worked in DME and I understand that pain point. But you also have to consider that patient experience. So I would say, not as a cop-out answer, but case-by-case basis, in my opinion.
Anyone else want to chime in?
Yeah, I think patients are lost in the care plan a lot. We believe that they'll get certain care at the DME, and Mary presented a great case study of a individual who didn't get as much follow-up, and then when they finally did, they got that treated, right? So some of it is, fixing that component of it. And so if that physician has everything, that great network that they're following that patient, all of that, sure, they have maybe more leeway to try things out. But I think if a patient in our standard care right now and with our society I would think you should go for what is going to best treat that patient with their comorbid conditions and all of that. Physician dependent, right? But I think the quality of care and that standard of care is very siloed. More and more these days. The company that does the sleep study is not the same company that follows that patient. So, what I would see in the hospital system is patients that are readmitting because of this lack of, follow-up and care. So it's physician dependent, All
right, moving on. Mary, it's for you from Edna Brown. She wants to know if EPR and C-Flex are the same.
Very similar. I think the algorithms and the devices were clearly proprietary to each of them, but they were both with the same kind of intention, right? To offer that extra relief on that expiratory breath that was there for them.
Yeah, I would just add they're both pressure relief ventilation algorithms, but the algorithms are drastically different from one another. But yeah.
I just want to bring this up on screen. It's not really a question. Link for CEUs, please, at work. Can you put it in the chat? It is in the chat. That's where it was placed. So we will post it again, Sabrina, when we get back after Q&A, but it is in the chat. Question for Trish. With ASV, a lot of times I feel like max pressure of 25 will almost always be reached when titrating my patients. it does its job, but I will hear feedback later on with the patient that suggests they don't tolerate it when the pressure ramps up too high on them. Do you feel it's best to suggest another study or have the primary lower the max pressures?
Great question. I think that, yes, sometimes patients, whatever they come to, their clinical condition, they'll react immediately to it. And almost we joke and say, well, that one's air hungry. We could have started at a CPAP of 15. But over time, are they going to be able to tolerate that pressure? So I think in the physicians I work with, they will take the approach first of lowering the pressures to a lower setting and then look at the compliance on more of a regular basis. Instead of at the next visit, they might do a weekly or a biweekly check of the compliance data and see what that does. We all know sleep studies are expensive. Bringing them back in the lab, you might go to a different modality. That's another machine. So the first approach is definitely, can we adjust the settings on them? At least for the physicians I work with, they go first on adjusting settings on the machine and truly look at compliance data.
I just got a question through. Actually, it's not a question, but I need to bring this up because somebody just posted a question, and I want to call the person out. Their name, their RPSGT number for their CEU. You need to fill out the form for the CEU. It's an evaluation that has to be completed. So just make sure you do that form, and that's how it will automatically trigger your certificate. And you should get that momentarily, by the way, after you complete that. Moving on. Dr. Lieutenant Colonel, this is quite an honor, sir. Can you please elaborate on how much should the epic duration be if we see a lot of CSA or epoch? That's, however you want to say that. Everyone has their own little twist on that one. Go ahead.
Okay. It's going to be how you see your events the best. Now, I'm going to do two things. As you're titrating the patient, 90 to 120 second paper speed is great. If you're 100% convinced it's central sleep apnea, 300 works as well. So you can see the pattern change. Also, though, I've never seen anyone titrate on 600, but you definitely, when you get to a good positive point, you want to do a back review of maybe the last hour. Bring it forward, look at it at 600 seconds. I've had people tell me that takes too much time. I sat down one time, I can look at an entire 6 hours at 600 seconds in less than 5 minutes. So it's just a really quick overview. But in terms of titrating in the moment, I recommend 120 to 300, but you might be more comfortable with 90.
Well, the Dr. Lieutenant Colonel is back with another question. Also, any new changes in management of TEXA?
Before I move on, I just want to add on that last note.
Sorry to cut you off.
There are functionalities within, I would imagine, quite a few acquisition softwares where you can take a step back and look at like a satellite view where you can do your titration or your review in 120 or 300 seconds, but you can also pane out and have multiple pages next to one another and easily see that full picture of what's going on. So in your software system, you may reach out to your support and just see if you have that functionality. That could be a nice tool to have.
Who wants to tackle the TEXA question?
I think we're just more aware of them.
Yeah, it's a tricky one when you're dealing with treatment emergent, right? Because in so many instances, we don't necessarily know what it is. Is it something that's going on with the patient? Like in one of the examples where it was maybe more of a physiological thing, making sure that we had the airway nice and open and maintained the whole time, help to resolve those types of things. It could be any number of things. It's a wild kind of rodeo that we're riding, and that's why in some instances it requires multiple visits for different patients, because I think that's one of the things in sleep medicine we're still trying to kind of nail down what could be causing that. Is there something else in the patient's medical history that might be suggestive they could be prone to this kind of thing that might be able to help kind of point us in that direction?
I would add also that I'd mentioned before, we're looking at the big picture during these studies, not these momentary events. So do give that patient time to settle in. Maybe you're already doing that in the lab right now, but just make sure you're giving them time to adjust to the therapy. I think Trish, you mentioned, was it about 40 to 50 minutes between pressure changes? Is that what you're running there?
On ASV, yeah.
For the ASVs, okay, yeah.
I'll add too is if you're central sleep, if you're treatment emergent, we kind of sometimes approach it too. If you get stuck in this pattern, we'll actually wake up a patient and sit them on the side of the bed and reset them. We get stuck in this pattern and we can't, nothing's breaking. Our pressure changes, nothing. We just sit them up, get their gas exchange back to where it is when they're awake and start over. And I'm big on go back to where it was going well and start again. So that would probably be, if I had to say one thing that I've seen that's worked that I wasn't using 5 to 10 years ago, it would be wake the patient up, change the gas exchange, and then go again.
One thing I could also throw back to, I think in Andrea's presentation where she brought up that we get patients with opioid medications that can cause centrals. I know that when I worked with a lot of patients that had been on opioids for extended periods of time, like more than 5-10 years, they tend to kind of have a reverse effect. The beginning of the night when they've taken their medication, that airway is pristine. They are perfect. All of a sudden we're treating them, and as that half-life wears off on their medication, now all of a sudden the centrals emerge. So you got to really kind of be attentive to the patient, really understand their history. Understanding what's going on there and what medications they're taking are really going to play a big role in how you actually treat and assess that patient throughout the night as well.
All right, going to move on. Rimawati wants to know from Trish, what is the limit for pressure support given in BiPAP ST?
We focus more, and again, medical director, lots of protocols. I'll share a little bit. I run a 18-bed lab across 3 facilities and rural and metropolitan. So my patient population changes a lot too. So I go back to a lot of, this is why I love rubrics. But for us, it's more how we set our backup rate first. Then we do have the freedom. We're encouraged to keep our pressure support tight at the 4 on BiPAP ST, but we can go up to 10. But I will tell you, our documentation has to be strong and we have to make our case on why we did it. Even if it goes wrong, that is okay if it goes wrong. If we have a great explanation on everything else wasn't working, I'm going to do my Hail Mary. But when we start out, we keep the pressure support close and we play more with the backup rate. And we watch in our lab, we'll watch the tidal volume.
If you have a look at the AASM guidelines as well, in that same link on that page under their diagnostic treatment portion, it does have the recommendation minimum of 4, maximum of 10 is the recommended guidelines.
All right, we're going to go to the next question. Manuel, I don't know why it's keep popping out like that. Manuel, does the BiPAP with backup rule also apply to treatment emergent cases? Thank you. Great presentation. Who would like that question?
Let me pull up the guideline here. Just give me 1 second. So
back to the previous person that had the question, any other therapies? This might be something we could try. I'll definitely put it out there with my staff and see if anyone has ever tried BiPAP ST to apply to treatment emergent. But I can say I don't have a case that comes to mind that I can share with you.
I had years ago, way back when I was in Wisconsin Sleep out in the Madison, Wisconsin area. Shout out to anybody that's there. We had a bit of a rule where we would do that and we would start that level and allow the patient to then go home, sleep with it for quite some time before then we would, if they still were having problems, then we would bring them back in lab and we would do an ASV titration on them. So again, some of that goes back to what Tricia keeps saying, you know, it's policies, it's procedures, it's what your medical directors have really established for your team.
And I did have a chance to check on that paper, that update from the December 2025, and it does specifically say treatment emergent centrals for in numbers 2 and number 1 with regard to the BiPAP therapy. So that is indicated in those rules that for treatment emergent central sleep apnea specifically.
Mary, yeah, this is for Mary. Do you recommend a full face mask for CSA?
I know years ago that was always kind of the thing. Doctors wanted to make sure that we had a full face mask on patients. These days, I think with the type of masks that we have that have come out for patients, the way we can better fit them, like Tricia said, getting a scan, helping to make sure we've got a better fit for them. Ultimately, I think across the board, patients in general tolerate PAP therapy better with a nasal mask. It's kind of our instinctive nature to want to breathe through our nose. Mouth is kind of a learned behavior to compensate for not getting enough. Not to say that there aren't patients that have obstructive nasal airways, just smaller, deviated septums, those kinds of things. Really got to kind of pay attention to the patient. I have seen techs who've done a nasal mask, and maybe if they are popping their mouth a little bit, apply a chin strap, see if that helps to kind of keep things closed up there. Overall, they tend to feel and respond a little bit better with the smaller mask, the smaller interface, but I wouldn't say that full face is a necessity when you do an ASV titration. At least my experience. Don't know if any of the other ladies have any input they would like to share on it.
Are any of you aware of any case studies showing a patient with failed modalities, then post-implant of a phrenic nerve stimulator, showing patients improvement of CSA?
I haven't seen any yet. I know for me, I haven't been able to yet come across any of these remedy type patients. I know that's one of the big devices that's out there right now. I'm hoping to see some very soon, and hoping that we can start to get a better understanding of their response to those things for some of that comparison and patient response.
I'm going to put this question up. This may be too deep. If not, we can get back to Stevie on this. For students who don't know, could you go over reimbursement criteria when switching to ST mode or ASV?
Tricia.
Do we need to put that in the parking lot?
Can I do a big asterisk and we can't advise on it, but if you want to weigh in on it.
We call our local DMEs regularly and say, what can we do with this patient? Here's where we're at. Maybe we got as far as 2 modalities and we're bringing them back for another. We will actually call the DME and say, what support do you need? Because our doctors, and I have 2 or 3 of my doctors who will tell me where they think this is going to end. Really helpful for our new staff. Like, here's what I think you're going to get. Don't be scared, go. So we'll call the DME in advance and say, this is your patient. What support do you need to get this done? That way we can get our letters of medical necessity done that go right along with our reports. So that's what I would say. If it's not a clear-cut case, find out what's needed to support your patient.
We have 3 questions left. I appreciate you guys being here. I think we'll field those and then we will knock it off for tonight. So we'll just go back to the director, Dr. Lieutenant Colonel once again. Superb presentation, everyone. I'm trying to fix CPAP for my patients as affording BiPAP ASV is out of the picture for my patients. Is this approach correct in your estimations?
Yeah, I mean, within that, it shows that 50% of these patient population can be fixed with CPAP. So CPAP is always a great place to start. Not all patients will end up being fixed on CPAP, but definitely it's a great place to start.
I'll share, and we can take this offline. We're creating, this might be something you'd be able to do. We've asked for a grant for advanced modalities, and every patient starts on a CPAP because we seem to be able to get those through indemnity programs and donations. And you start on your CPAP, and if you fail, you turn in your CPAP and you qualify for one of the foundation or the grant advanced modalities, and then your CPAP goes back into the system for the next patient. So you definitely can reach out to me. This is a program we're collecting the data on right now and trying to launch for our community that can't afford, they don't have any support to get any machine, and we can only get them CPAPs.
Anyone else have any comment on that? Steph Smith, I did most of the scoring for the Advent HF trial studies using ASV, had an auto EPAP. Will ASM be elaborating more on scoring criteria with respect to differentiating CSR in those subjects that present with both a central and a strong obstructive component, as they can have underlying CSR respiration with overlying obstruction? Examples would be typical patterning of O2 DSATs, band, timing of arousals at event termination, or maximum ventilation, especially as it applies a differentiating hypopneas to assist in titrations. Who likes that one?
You know, I don't know if we can answer for the ASM. I would
Right.
love for them to be like, that is a great thing, Steph. So what I would recommend is actually email ASM suggesting that. I think that is all the outline, you know, the guidelines that you outlined. I think that is wonderful. And we're very lucky to have you in the field.
Yes.
Allow me to answer for them. No, I'm kidding. Thanks, Steph. Good question. By the way, the slides are going to be available. The ladies have agreed to make their slides available. So we'll send a follow-up email after the webinar. Give us a few days. We'll get that out to you with a link to rewatch this and also the slides. So Lacey Adams is going to bring us home here with her question for the ladies. I've learned that high loop gain patients are sensitive to CO2 changes. EPR can push them past the apneic threshold on masking treatment emergent CSA. For some patients starting on CPAP, do you recommend text making sure EPR flex is turned off while they titrate in real time if centrals emerge? I've got a show more button, but there's nothing there. So good. That's the whole question.
I'm a big advocate for EPR off.
Off,
Yes.
definitely off.
Yeah.
Are
On all
you guys unanimous
titrations.
on that?
Yeah.
Yep.
Yes.
Yeah.
Also keep in mind, are you guaranteed that your patient's going to get the device that has EPR on it? You might have spent 6 hours in a lab creating a beautiful study and they're put on a device that doesn't have EPR.
Yeah.
that-
I also found that, especially when you're dealing with a patient that's never done PAP therapy before, I know that, you know, they say, well, you can titrate rapidly, things like that. I would rather the EPR off and I slowly increase them at 1 centimeter at a time just to allow them to acclimate. You don't understand how sensitive you're going to be until you're in that moment. And suddenly it's like your spidey senses are on high alert. It's a fight or flight kind of situation. So take your time, be gentle with the patient, acclimate them to the therapy. Try to keep that EPR off if you can, because like Trish said, you can't guarantee that they're going to get a machine where it's going to be there.
Jill, any comment on this one? I'm going to give you each a chance to comment on this, or anything else you want to say before we
Yeah, well, it's just kind of like
head off?
there's no need to add extra, comfort settings and adjustments to the modality when you're trying to still hone in and fix one issue without having to add other pieces to it. Because if your patient is having discomfort later, well, then can you maybe try the EPR if they need it at a later point in time? Well, it's already in use. And it kind of masks the data that we're trying to look at, right? And you saw Mary's great example from her last case study there. So it does and can have an impact. So my recommendation would be, well, not recommendation, what I would do and did is start with it off. And to Trish's point, we don't know what machines the patients are getting.
Andrea, any final comments for us?
No, just, to point out that Lacey Adams is actually, she spent a lot of her career as a sleep coach following up with patients like that. So she is a great resource for this field too, to understand some of the dynamics and following up with patients and how complicated they could be with the different, type of units that we put them on.
Good. Mary, anything else?
No. Thank you all for letting us talk to you for this long about central sleep apnea.
Well,
Fun to share the stage with these ladies.
I think we should do this every week. This will be good. But I want to thank our sponsor, Cadwell, for tonight's amazing webinar, and our panelists, Jill West, Andrea Ramberg, Mary Blevins, and Trish Fair. Thank you guys very much. It's been really wonderful. This will be available. And thanks for making your slides available. And we will see you out there somewhere on the sleep road.
All right.
Thanks, guys.
Thanks, everyone.
Thanks, everyone.